Thanks. Hey guys, I'm Amit. I'm one of the junior doctors working as a GP trainee in Leicester. So I'm going to talk to you today about rheumatoid arthritis. And yeah, so let's just get on with it. Um, yeah, so basically, today's aims and objectives. So we're just going to cover the etiology, the pathogenesis, common signs and symptoms, investigations and diagnosis and treatment. There will be questions throughout the slides, and yeah, it should hopefully be less than 30 minutes. Okay, so basically, rheumatoid arthritis is the most common inflammatory arthritis in adults, characterized by progressive joint destruction and deformity, usually involving the peripheral joints. It's more common in females than males by a factor of 2 to 4 times. Seen, yeah, the middle-aged age group around 30 to 60 years old. And by the time when the symptoms start to within 2 years, 1/3 of them would just stop working because of how debilitating the symptoms are. So scenario one, so a 47-year-old woman presents to a GP with complaints of worsening pain, tiredness, and stiffness of her hands for 2 months. This is affecting her work. On examination, there's pain and swelling present over the second and fourth metacarpophalangeal joints and her wrists. So her bloods show rheumatoid factors are normal, but high CCP. So given the likely diagnosis, what is the next step? Give.
In the chat or Q&A
Yeah.
if you put
Yeah,
your answers
yes.
in. Yeah.
I was just trying to find the Q&A because that's going to be my next mission, like the play button. Okay. Yep. So those who request X-ray, yep, it's correct. So yeah, so we'll go through the answers. So prescribing methotrexate. So methotrexate is not a bad option, but again, because she's in a GP practice right now, it's way too early to start it. And but yeah, it is a definitely potential treatment later on down the line. For steroids, so steroids are mainly used for the treating the flare-ups for rheumatoid arthritis. But before diagnosing and starting the medical treatment, it may just mask the symptoms and delay the diagnosis. Physiotherapy is not a bad option, but again, we need to first initiate the medical treatment, confirm the diagnosis, and then we'll get physio going on once the patient has been started on their regimen. Yeah, so immunology, just don't do it current yet. And then, yeah, so coming to the X-ray, yeah, as per the NICE guidelines, yeah, so do the X-rays of the hands and feet for all patients suspected with rheumatoid arthritis, and will require urgent rheumatology referral to get the ball rolling. So the etiology for rheumatoid arthritis, there is a huge genetic predisposition for it, especially for if you have a first degree relative, you have 5% more chance of actually getting it. So the main genes involved include HLA, DRB1, and PTVN22 genes. So if you have these, if you have a strong genetic predisposition, these environmental triggers may start off the process. So the main ones include smoking, infections, especially with viruses like Epstein-Barr virus, parvovirus, and HCV. So a lot of so the microbiota has a minor role, especially in your oral flora, with Porphyromonas gingivalis, and in your gut, the Prevotella species. So these are very common in they're quite high in the people with rheumatoid arthritis. And then diet, lifestyle, the recreational activities, and hormonal, particularly low estrogen levels. So how it works is with the genetic factors and the environmental triggers, your body will generate autoantibodies like the rheumatoid factor and citrulline protein antibodies. These attack your own body tissues, particularly the synovium of your joints. With this, just calls upon the inflammatory cells which infiltrate the synovium, release the pro-inflammatory cytokines like TNF and interleukin 1s, which leads to joint destruction and causes all the symptoms. This continuous destruction of these joints will lead to further changes in the body and cause systemic complications as well. So clinical features can be divided to articular and extra-articular features. So before you have these pain in the joints, a lot of patients will complain of very general issues like weight loss, fatigue, fever, with sometimes night sweats. Doesn't really point to rheumatoid arthritis, so it's very hard to actually find it quite early. But they later on come with pain and swelling of the small joints in hands and feet. So it's symmetric. So basically involves both sides. And yeah, regarding the pain, it usually is the worst in the morning and gets better throughout the day. With the joint stiffness will always be more than 30 minutes for these patients. So the commonly involved joints, proximal interphalangeal joints, metacarpophalangeal, metatarsal, and wrists. One way to keep it in your head all the time, just make a fist. So these two joints are always involved, and then you can't see your distal interphalangeal joints. For some reason, it is your distal interphalangeal joints are spared, along with your sacroiliac, your vertebral joints, except your C1 and C2, but that'll be very late in the disease. So if left untreated, yeah, it can definitely progress into these deformities like swan neck deformities, boutonnieres, ZZ deformity of the thumb, and ulnar deviation of fingers. We'll have a look at some photos of it. So yeah, this is the swan neck deformity, just flexion of your distal interphalangeal joints and extension of your proximal interphalangeal joints. Then your boutonniere is pretty much the opposite. So the flexion of your proximal interphalangeal joints and the flexion of your distal. Then yeah, so your Z deformity is just the interphalangeal hyperextension with exaggerated adduction of your first metacarpal joint. So another scenario, 62-year-old female is referred to the rheumatologist, outpatients with morning stiffness and pain in both hands. On exam, she has pain and swelling of the metacarpophalangeal joints. She's suspected to have rheumatoid arthritis and sent for x-rays of both hands. So given the likely diagnosis, which x-ray findings would support it? Okay. Yep. So I just need to get rid of this, my screen, it's blocking the way and can't find my mouse. Okay. Yep. So yeah, so the just articular osteoporosis is the most likely pointing feature towards rheumatoid arthritis. these other features are more seen for osteoarthritis than rheumatoid arthritis. So this is definitely leaning more towards rheumatoid arthritis. Yeah, so the other findings can be seen for rheumatoid arthritis, but yeah, the just articular osteoporosis is what we look for. Unfortunately, I couldn't find a decent photo which I can incorporate the slides because they are being copyrighted. So pretty much this is how it looks like. I try to make a schematic diagram. So basically, you can imagine your phalangeal joints and the interphalangeal joints just going to be less density just in the juxta articular area. So that's just how you find it on X-rays if you ever come across it. So the extra-articular manifestations are quite extensive. It affects pretty much all the systems. So cardiovascular complications include myocardial infarctions, congestive heart failure. For pulmonary, you do get into interstitial lung fibrosis, even pulmonary nodules. You can develop these things called rheumatic nodules later on, which is pretty much these small bumps which you find in your fingers and also your forearms near your elbows. The commonest hematological manifestations include chronic anemia and iron deficiency anemia as well. Neurological complications, yes, you got peripheral neuropathy, and also depending on the deformity of the joint involved. So suppose if you get a rheumatoid arthritis of your wrist, you can get things like carpal tunnel syndrome. Then Sjogren's ocular manifestations include anterior uveitis, can get vasculitis. Then psychological, you can imagine someone with this disease, because of how quick it progresses, and their life pretty much gets really affected. So most of them do have some form of depression. This is my experience. So the diagnosis, so we mainly from a primary care setting, look at history and the clinical findings and measure the functional ability to get a baseline. So from the primary care, when you suspect someone with rheumatoid arthritis, sorry, I need to go back away. Sorry. Yep. So in the primary care setting, any synovitis of undetermined cause, you can refer directly to the rheumatologist. And also if it's involving both hands, where do I? Sorry. Okay. 1 second. Okay, that's better. Yep. So, all right. So history and clinical findings. You go through that, and so on your right there are these specific conditions that you can do a direct referral. So synovitis of undetermined cause, yes, and urgent referral to the rheumatologist if there is small joints involved in the hands or feet. If it's more than one joint affected, and there's a 3-month delay between onset of symptoms and seeking the medical advice. So the common bloods, we order anti-CCP, rheumatoid factor, ESR, C-reactive protein, full blood count usinase. And then, yeah, you can request these x-rays and go through changes like how we discussed. So this ultrasound and joint aspiration that you don't have to worry about unless if you just go into the secondary setting and if there's actually doubt in your diagnosis. Yeah, it's very rare that you actually need to end up doing joint aspiration unless if you're actually needing to differentiate with another form of inflammatory arthritis. So the treatment is a multidisciplinary approach. So yeah, need to involve other specialties depending on the severity and the involvement. So main thing is just to control the pain, swelling, try to prevent the deformities as much as possible, and prevent the radiographic progression. Try to maintain the quality of life, control the extra-articular manifestations. So in the NHS, we usually follow a treat-to-target strategy. So we aim to achieve remission or at the lowest disease activity if remission cannot be achieved. So in a scenario, a 45-year-old female with background of rheumatoid arthritis on methotrexate presented with exacerbation of symptoms of joint pain and swelling. This is interfering with her daily activities like eating and bathing. On exam, her rheumatoid arthritic joints were tender and tender than normal and swollen. Vitals were okay. Given the likely diagnosis, which of the following drugs would you consider? Okay. Yeah. So yeah, steroids. So yeah, like I said earlier on, so steroids is useful to control the flares for rheumatoid arthritis. So colchicine and allopurinol are useful in gout, but it's not going to help you in this. And paracetamol and NSAIDs are mainly used for the pain management, depending on how much painkillers the patient is using. Yeah, usually later on the disease, usually patients end up being on so opioids if their pain is really severe, but or really strong NSAIDs. But during flare-ups, it's very rare that they're gonna give any benefit. So yeah, the pharmacological treatment, yeah, the main pain relief can be can be used with NSAIDs, like ibuprofen, naproxen, celecoxib. So DMARDs, the treatment is always started with the rheumatologist. So despite, yeah, it's quite easy to start, but the thing is they need to actually go through the MDT and all these things before we actually begin. So yeah, there are biologics and non-biologics. The methotrexate and hydroxychloroquine are very commonly used rather than rituximab and adalimumab. And then you have these glucocorticoids for every time when you want to switch these DMARDs or you want to manage flares. So yeah, this one you don't really have to know when you're in practice unless if you end up being a rheumatology reg or like later on in life. But the way they do it is just like with all drug regimens, you start with one. So start with either methotrexate, leflunomide, sulfasalazine, as soon as possible, and yeah, escalate the dose based on the response. And then yeah, if you can add in others if you're not getting the appropriate response, so if monotherapy isn't working. So each DMARD has its own side effect. So I'm not going to list all the DMARDs and their side effects. That's for you to go and read. But yeah, it's the common ones are definitely methotrexate, sulfasalazine, hydroxychloroquine. These are very common, so I would definitely have that in the tip of my tongue. So non-pharmacological treatment, so diet modification to a Mediterranean diet can offer some help. Stopping alcohol and smoking. Try for weight control just to reduce the load on the joints, especially in the lower limbs. And physiotherapy. So long-term patients with physio, they have their own with non-pharmacological treatments like using TENS machine, acupuncture. And then surgical, so there's a whole array of surgical options available: tendon repair, transfer, synovectomy, reconstructive surgery, and joint replacement in the end. The thing is, in the NHS, the problem is all these joint replacements. A lot of people end up being in the waiting list for quite a number of months to even years, especially now. So when you do start practicing, I think the pain management and just monitoring is one big thing. So another scenario: a 44-year-old woman came to a GP for metacarpophalangeal joint pain. She has been using ibuprofen with some effect. Examination reveals bilateral metacarpophalangeal joint swelling and tenderness consistent with synovitis. Temperatures were fine, vitals were stable, bloods are requested, and the patient is booked for a follow-up. So given the likely diagnosis, what is the most appropriate management option? Yep. So urgent rheumatology referral. So the patient has new synovitis and also has multiple joints involving both sides. Can refer urgently to rheumatologist. So routine referral. Because of how long it takes, by the time they end up finally actually seeing the rheumatologist, they probably already would have developed some form of deformity. Reassuring and follow up blood tests. It's inappropriate, to be honest. Emergency department referral is also inappropriate. Because because the temperature was fine, doesn't really indicate any septic arthritis, so there's no point for any joint aspiration. That's about it. If you have any questions, feel free to contact me. I think it would be really great if you guys can give me some feedback. But I forgot to put the QR code. Thanks for listening to me, and I'll see you in a couple of weeks. I'll try answering some of your questions in the Q&A section, so let me know.